Hi everyone, and thank you Natalie. Good morning and welcome to this webinar on safeguarding non-mobile babies. So today the focus is on safeguarding non-mobile babies. Abuse and neglect of children under the age of 1 year is of particular concern because the evidence shows them to be the most vulnerable to adverse long-term outcomes in all areas of development. This webinar will highlight the importance of professionals working together to maintain a focus on the needs and experiences of very young children, especially those in vulnerable families. Professionals will gain an understanding of safeguarding for these very young children. We will also provide information on the key messages to be given to parents to protect non-mobile babies. So my name is Fiona Townsend, and with me today is my colleague Jayne MacIver. We manage the Early Years Enhanced Provision Service. This is a service offered to referred vulnerable families with children under 2 years of age in Bristol.
So good morning, and as Fee said, today we're here to focus on safeguarding babies and children under 1. The webinar is entitled Safeguarding Non-Mobile Babies. This is a generic term and is a classification for any child who is not yet independently mobile. It covers children who are generally under 1 year of age, but can also include children over 1 who have an additional developmental need, which means they are not independently mobile or have an illness which makes them more susceptible to injury. In developmental terms, young children can be divided into 2 groups, non-mobile and mobile or partially mobile. And from a safeguarding perspective, the distinction in these groups is important. This is because there are certain injuries that do not usually occur as a result of an accident in a non-mobile infant, such as bruising or fractures. For example, a baby rolling on its tummy should not cause bruising or injury, whereas toddlers or children learning to walk, run, climb can be expected to get appropriate bruises and bumps. So, why do we need to specifically highlight the non-mobile group of infants? Research tells us that abuse in this age group is particularly damaging as the child has not had the time to gain the quality early experiences which may have helped them to build a degree of resilience to help cope with later adversities. And key learning points from serious case reviews show that it can be difficult for professionals to find a balance between supporting new parents and recognising and addressing the risks posed to babies. This is particularly evident in parents who are vulnerable or have experiencing multiple challenges, as their needs can easily overshadow the needs of the very young children. So today, as Fee said, we hope to outline some of the core principles around safeguarding non-mobile babies and offer guidance for professionals to identify and act appropriately on concerns.
So here's a brief overview of safeguarding, which I'm sure you already know. Primarily, parents and carers have care for their children. However, local authorities have overarching responsibility for safeguarding and promoting the welfare of children in their area. Safeguarding is defined in the Working Together to Safeguard Children 2018 guidance as protecting children from maltreatment, preventing impairment of children's health or development, ensuring that children are growing up in circumstances consistent with the provision of safe and effective care, and taking action to enable all children to have the best life chances. Today, we intend to talk about child protection with regard to non-mobile babies.
So safeguarding the youngest children. We all know it's critical to safeguard all children. However, as we've identified, non-mobile babies are particularly at risk due to their dependency needs and therefore must be recognised as a most vulnerable group. A research study in 2015 found that bruising in a baby who has no independent mobility is very uncommon. And in 1999, a large research study regarding bruising in infants and toddlers was undertaken to determine the frequency and location of bruises in normal infants and to determine the relationship to age and developmental stage to bruising. The overarching conclusion from this research was that those who don't cruise rarely bruise. This is a really useful statement to keep in mind. It also found that bruises are rare in normal infants and pre-cruisers, but unsurprisingly become common in cruisers and walkers. And that any bruise in an infant younger than 9 months should always lead to consideration of abuse and illness. There was also another serious case review following a suspicious death of a baby in South Gloucestershire, which identified that the baby had been presented to professionals on a number of occasions prior to their death, with what appeared to be potentially plausible accidental minor injuries. And the infant's deaths from non-accidental injuries often have a history of minor injuries prior to hospital admission. It stated that non-mobile babies cannot cause injuries to themselves and therefore must be considered as a significant risk of abuse. This review led to the creation of the multi-agency guidance for injuries in non-mobile babies. And in our authority, this document can be found on the Keeping Bristol Safe Partnership website. We will look at this in more detail later and provide you with a link. However, it's important to note that this is the guidance that we should all work with when an injury has occurred, which involves a non-mobile baby. So to better protect babies, we need to get an understanding of who are most at risk. We are already identified that babies of parents who are vulnerable or have overarching needs of their own are more likely to be at higher risk of abuse and neglect. So let's take some time to consider which parents might be seen as vulnerable or which might be in the higher risk group. And we would suggest a list would include parents with mental health problems, parents with substance misuse issues, young parents, parents with learning difficulties, parents who've experienced abuse themselves, families living in areas of high deprivation and experiencing poverty or poor housing, women who have asked for a termination of pregnancy, and parents who may not recognise that they are in an abusive relationship. I'm sure that you can think of several situations and cases that you've worked with or supported where you feel a baby is vulnerable or at high risk of abuse. However, interestingly, another critical piece of research has evidenced that vulnerable parents who manage to care for their babies with support from family and professionals may not be able to maintain that level of care needs on their own. And it stressed the importance of professionals remaining vigilant in these circumstances and ensuring that there are strong support plans in place where professional support is coming to an end. So learning from serious case reviews and the NSPCC November 2017 review identified some important areas for professional practice that need improvement so that we can better safeguard very young children. And in summary, they said, practitioners should remember that babies do not bruise themselves by lying on dummies or banging themselves with infant toys or flopping forward and banging their heads against their parents' faces. And although we should always consider mobility stages such as crawling and walking, and the fact that in infants this can vary considerably, we also need to be observant of particular signs and symptoms and ensure correct procedures are followed, however plausible the reason for the injury may appear. We should keep in mind that in non-mobile babies, even small injuries may be significant because they may be a sign of another hidden injury or a pointer to serious abuse. The reviews also identified that professionals must work together and communicate effectively to maintain a focus on the needs and experiences of very young children, especially in vulnerable families. Multi-agency information sharing was highlighted as critical because it allows for sensible, informed judgment to be made regarding a child's safety. Information sharing across agencies builds a picture and puts the puzzle pieces together, which makes safety plans accurate and safe. Asking questions of other professionals and calling meetings if you have a concern was also mentioned as essential practice. A thorough assessment of the whole family circumstances is critical. It's not just about the here and now, it's about gathering parental history and considering the impact on parenting capacity. This assessment must include both carers, and it was highlighted that there's often a lack of information on fathers. A practitioner must engage with all the adults in a baby's life to understand who is doing the caring, who is the key person, who is the main carer or the attachment figure. Professionals should always question and challenge, especially if there's a lack of appropriate responses, like not seeking medical advice or reporting incidents. But we should also listen to parents, especially when they are saying that they're not coping. We need to improve on professional understanding and recognition of disguised compliance. This is where parents appear to be accepting and agreeable to the support we're offering, but in reality, they are not engaging. Having said all of this, the overarching factor from the reviews is that in cases involving babies, professionals' focus must always be on the child and not on the complexities of the family circumstances. And there is a need to continuously think, what is the lived reality for this baby?
Okay, so looking at statistics, here are some for you. So severe child abuse is 6 times more common in babies under 1 than in older children. Infants under the age of 1 are more at risk of being killed at the hands of another person, which is usually their carer, their main carer, than in any other age group in children in England and Wales. Almost half of the children who was the subject of a serious case review between April 2003 and March 2007 were under 1, and the youngest child in the family had a heightened level of vulnerability and risk. Analysis of 368 serious case reviews in England between 2014 and 2017 relating to death or serious harm revealed that the largest proportion of incidents related to the youngest children, 42% of them being under the age of 1. Of those, 51% were under 3 months of age. In contrast to the high proportion of children known to social care, a minority were on a child protection plan. In the 2020 Child Safeguarding Annual Report, babies under 12 months continue to be the most prevalent group notified, and there were a high proportion of cases involving non-accidental injury and sudden unexpected infant death. In these cases, parental and family stresses were the most significant factor in escalating risk. In some of the cases, face-to-face had been replaced with telephone or video contact. A key point of learning was that adaptations for COVID safe practice in lockdown should maintain at least 1 face-to-face visit from a midwife and health visitor for families with newborns.
So, categories of abuse. As I'm sure you know, there are 4 main categories of abuse: emotional, neglect, sexual and physical. This is the same for adults and children of any age. It's important to remember that the categories of abuse seldom occur alone and are nearly always interlinked. Neglect and emotional abuse have been evidenced as the most difficult types of maltreatment for professionals to identify, yet are the most likely to occur alongside other types of abuse and the most likely to reoccur. Learning from case reviews show us that it's difficult for professionals, but we all need to be aware and open to the possibility that parents and carers can neglect to care for their babies, and in some cases babies are deliberately harmed. Cultural differences, circumstances such as finance, health, personal situations can all influence how a baby is cared for, but they are not an excuse for abuse. So let's look at the categories individually. Emotional abuse. All forms of child abuse include an element of emotional abuse, although it can also be experienced on its own. It is argued that this is the most damaging of all forms of abuse in early childhood because the perpetrator is almost inevitably the primary carer, who is the person responsible for enabling infants to fulfill their developmental tasks and the person that they are dependent on. Neurological science research has shown that the lack of emotional stability in early childhood has a toxic effect on the developing brain architecture and on physical health. A lack of an appropriate attachment figure is emotional neglect. Attachment in this context refers to the pattern of relationships we have with our parents and carers early in our lives. It is the emotional bond that forms between a parent and a child from birth, and this has a huge impact on our early brain development, which has lifelong implications. Being cared for by an abusive attachment figure can leave an infant acutely or chronically dysregulated, and this will impinge on all future relationships. Some red flags to look for in emotional abuse with babies would be babies who have a blank expression, poor eye contact, or very quiet or excessively crying, because they are likely to be lacking in some kind of emotional stability and security. Observed failure to bond with baby, so poor attachments, they may result in or be a result of emotional harm and abuse. A lack of parental interaction with baby, lack of interest in them, or not engaging in conversation with you about baby. This can suggest that there's an emotional imbalance. Parents who are physically or emotionally absent, they're literally not able to engage or respond to baby. This could be due to mental health, substance misuse, domestic violence. But whatever the reason, for a very young baby, this will leave them feeling vulnerable and emotionally insecure. It may have an enduring impact on their ability to regulate emotions in the future.
So moving on to look at neglect. So detection of neglect relies heavily on accurate observational skills, record keeping, and multi-agency communication. Recent research shows that neglect can have a significant impact on children's neurophysiological development and can produce elevated levels of stress chemicals which affect their brain development. So red flags may include being constantly smelly or dirty, inadequate supervision, which could result in injuries, including burns or scalds, not giving prescribed medication or treatment for medically diagnosed conditions, repeated failure to take baby to essential follow-up appointments, persistent failure to engage with relevant child health promotion programs, such as immunisations or health and development reviews, not seeking medical advice when necessary, jeopardising the health or the well-being of the infant, particularly if they are in pain, not feeding properly, so babies having an inadequate or inappropriate diet, suffering severe persistent infestations such as head lice or scabies, constantly being dressed in inappropriate clothing, for example, not enough layers in the cold weather or shoes that are too small for baby. So moving on, looking at sexual abuse. Sexual abuse of babies under 1 year is not common, but we should be alert to discharge, bleeding or injuries in girls' and boys' genital or anal area. Other injuries that might be sexual, such as bite marks on the buttocks or bruises on the inner thighs.
And lastly, physical abuse. This category is vast in its complexity, but what is important to stress is that non-mobile babies are particularly vulnerable to physical harm due to their age, developmental stage, and dependency on the adults around them. And any injury in a non-mobile infant is a cause for concern. If you remember, we have said research evidence found that those who do not cruise rarely bruise. Rough play is not appropriate activity or an acceptable explanation for bruises on babies. And babies can have serious injuries such as fractured ribs or limbs without any external signs and have limited ways of letting us know about it. Babies always require paediatric assessment, x-rays and other tests to make a diagnosis, and therefore should be referred to appropriate health services as soon as possible if you have a concern. And as we said, there is a multi-agency guidance which steps us through the process we should always follow when there's an injury to a non-mobile baby. Shaken baby syndrome, also known as abusive excuse me, head trauma, shaken impact syndrome, inflicted head injury, or whiplash shake syndrome is a serious brain injury resulting from forceful shaking of an infant or toddler. Analysis of the NSPCC figures found that more than 220 infants in the UK were killed or injured as a result of being shaken in the past decade. And research has shown crying to be the most likely trigger for shaken baby syndrome. Out of 1,253 serious case reviews published on the NSPCC website from 2008 to 2018, 229 of these cases involved a child being shaken. So some red flags for physical abuse in babies include drowsiness, poor feeding. This can be plainly apparent or quite vague. This can obviously also be connected to other medical issues or illnesses, but it can be an indicator of physical harm. Single bruises on the cheeks, ears, chest, arms, legs, hands, feet or trunk. Bruised lips or torn frenulum, which is the small area of skin between the inside of the upper and lower lip and gum. Lacerations, abrasions and scars, burns and scalds. Pain or tenderness or failure to use an arm or a leg may indicate an underlying fracture. The small bleeds in the whites of the eyes or other eye injuries. Deliberate poisoning or suffocation, which can present as sudden collapse, coma, stopping your breathing, or bleeding from the mouth and nose. Shaken injuries in young infants can present with or without external injuries, but symptoms can include minor bruises to the head, arms and chest, vomiting, poor appetite or feeding problems, breathing difficulties, convulsions or fits, drowsiness, pale or blue coloured skin. The soft spot on the top of the head would be bulging, dilated pupils, tremors and shakes, and the inability to focus or follow movement with their eyes, or even coma and unconsciousness.
So whilst bruising is the most common injury to a child who has been physically abused, please be aware that babies can be born with skin marks that could be mistaken for bruising. Birthmarks or coloured marks on the skin that are present at birth or can develop up to 3 months of age. So a blue-grey spot can look like a bruise, and these are most common on babies with darker skin. So midwives, health visitors and GPs should check for any and record any birthmarks or injuries occurring at birth. These should be recorded in the baby's red book. And in early years settings, when a new baby or child starts, questions should be asked and records made of any birthmarks. So on the Keeping Bristol Safe Partnership website, there is a blue spot marks information sheet. So we have tried to bring all the guidance we have mentioned today together in one place for you. Here we have some national and local statutory guidance for safeguarding all children. So there's links on this slide. So there's the Working Together to Safeguard Children. This is guidance on interagency working to safeguard and promote the welfare of children. This is the primary document for multi-agency working. There's the Keeping Children Safe in Education. This guidance is for schools and colleges on safeguarding children and also on safer recruitment. This is the Bible for people working in education. Please be aware there is a 2022 guidance which is under consultation at this time. So then there's the South West Child Protection Procedures. This is the child protection procedures for the whole of the South West region, and within this is the Bristol Safeguarding Partnership Procedures. This is a very useful resource. Something that professionals do need to think about is food safety. So there is guidance under the Help for Early Years providers. This document will give advice on foods for babies and young children, as tragically a child dies in the UK every month from choking, and hundreds more require hospital treatment. So in addition to this guidance for safeguarding children, there is a multi-agency guidance for injuries in non-mobile babies. The aim of this guidance is to ensure that professionals are aware that even minor injuries could be a pointer to serious abuse in non-mobile babies. Know that such injuries, however plausible, must routinely lead to multi-agency information sharing and make referrals as appropriate. Professionals not working in health should always discuss an injury in a non-mobile baby with a healthcare professional as soon as possible. And this is the guidance that you can print off online. So, what support and services are available for families with babies? Obviously, there's statutory services which are available to all new parents. These include seeing a midwife during pregnancy and in the first few days after birth. The health visitor will take over from the midwife, and this will include a new birth visit, a 6 to 8 week postnatal visit, then a 9 to 12 month developmental review. The GP will also see the baby for immunisations at 8 weeks, 12 weeks, 16 weeks and 1 year. So up to the age of 1 year, a baby may only be seen 11 times by professionals. So universal services which are available to new parents are services within children's centres, which include breastfeeding support, stay and play, baby hubs and universal parenting courses. These may all be signposted by either the midwife or health visitor. They may get information when they see their midwife or health visitor. There are additional services and support available in Bristol to families. These are all by referral. You may have heard of some or are involved with some. So there's an enhanced health visiting service, which is now called Universal Plus. This is offered when there's a need identified, and this is usually a time-limited category. Then there's Universal Partnership Plus, also known as UPP. This is the highest level of service and is allocated to all families with safeguarding concerns and social care involvement. Under this service, families have a minimum of a visit every 3 months. Universal Partnership Plus has 2 subcategories, one for looked after children and one for children with additional needs. The perinatal mental health team is also something that is offered in Bristol. So families are identified and referrals are made by any health professional who's working with an individual. So the perinatal mental health team are a team made up of mental health nurses, mental health support workers, psychologists, parent-infant therapists, occupational therapists, social workers, nursery nurses, and specialist psychiatrists. Health visitors work in conjunction with the specialist perinatal staff at the maternity hospitals. Family support workers, they offer identified programmes of support. They come under social care but are based in children's centres. Across the city there are 3 main hubs, which is when there's one in the north, one in the south and one in East Central. Enhanced provision, which is a service only in Bristol. So Jayne and I are responsible for managing this scheme. So it's where vulnerable under-2s are placed with identified childminders. We receive referrals from health visitors, social workers, family support workers, or any other professional working closely with the family. We have approximately 50 placements at any one time across the city. Families in Focus, this is targeted support to children and families. And then there's a family nurse partnership. This is instead of a health visitor, and it's offered to young parents, usually under the age of 24, who are partnered with a specially trained family nurse who visits them regularly from these early stages of pregnancy until their child is aged between 1 and 2. Evidence shows that teenage mothers have high rates of poor mental health for up to 3 years after birth. Their children are at 63% higher risk of living in poverty, and at the age of 5, children of teenage mothers are more likely to be behind on a range of developmental outcomes, including as much as 11 months behind on verbal ability. So family nurse partnerships provide intensive support and can reduce inequalities by enabling young parents to help their child succeed, despite the adverse circumstances they live with.
So then finally, we just wanted to end by focusing on some key messages that we could all offer to parents. And everyone's role in sharing the key messages is critical, and by talking to families and supporting them and helping them with understanding of how to avoid some of the specific risks to their babies, we can help to reduce the number of babies who die or are abused. We have identified 4 topics that we think greatly impact on safeguarding non-mobile babies, and would like to share some key messages with you that may be useful for you to pass on to parents that you're working with. Starting with SUDI, sudden unexpected death in infants. This is rare. However, unfortunately, over 200 babies nationally die every year. And as professionals, we can watch out for some risk factors and be aware of, and these include low birth weight, poor postnatal care, alcohol and drugs during pregnancy or after, overwrapping of a baby, covering their heads or using pillows and duvets, and co-sleeping. Encouragingly, we now have accurate information about 3 key points to share with parents which will help prevent SUDI. Number 1, always put baby on their back for every sleep. Number 2, keep them in a smoke-free environment day and night. And number 3, ensure that they have a clean, flat, safe space. So avoid soggy mattresses or second-hand mattresses in cots. Moving on to coping with crying. Oh, sorry, I didn't say that there's more information for parents available on the Lullaby Trust, and we'll put a link up on the next step regarding SUDI. So moving on to crying and coping with crying. Crying has been identified, as we said, as the main trigger for shaken baby syndrome, and is almost definitely integral to many child protection incidents involving non-mobile babies. So some of the key message we can offer to parents as a reassurance would include that babies cry for lots of reasons, but sometimes they cry for no reason. And this is because their brains have not yet developed the circuitry that allows them to self-control or to understand. Crying is a baby's way of telling us something, and neuroscience has shown that it's meant to be upsetting for the carer to hear. This is to make us pay attention to the baby. We all recognise that this can be incredibly upsetting and stressful when a baby continuously cries after you've tried everything to settle them. But a baby will not harm themselves by crying, and the crying will eventually stop. It's normal to find it difficult to cope with a crying baby. At around 5 months of age, a baby's cry becomes more purposeful, which means that a baby is more likely to cry for a reason, such as hunger or being uncomfortable or feeling emotionally insecure. So there are things that parents can do more purposefully at 5 months, from 5 months on. And then talking about their experiences and seeking support for themselves and their baby is a positive thing to do, and in no way means that they have failed at being a new parent or carer. There's a website called ICON, and the initials ICON can be used when they stand for I, infants crying is normal, C, comforting methods can help, O, it's okay to walk away, and N, never ever shake a baby. The ICON website has further information and advice on coping with crying, and the link is on the next slide. Thirdly, promoting and optimizing early brain development. Simple actions can optimize early brain development. Parents need to know that babies' brains double in size in the first year of life, as billions of connections form pathways in the brain in responses to their experiences and interactions from parents and carers. Therefore, how their carers act and respond around them greatly influences their early brain development. Rapid growth and development of the structure of the brain continues through to the end of the 3rd year of life. So what happens to a baby during the first 3 years of life is critical to long-term health and well-being. Experiences, interactions, and environments all shape a baby's brain for life. Healthy brain connections form most effectively through unspoken interactions, gestures, and bonds, such as cuddles and smiles, and familiar sounds and actions, smells, and touch. All of these can be achieved through simple routines and familiar actions, such as feeding, bathing, changing nappies, or just simply cuddling and smiling and talking to baby. Neuroscience has proved that positive attachment relationships build brains and promote lifelong health and well-being. The way a parent or carer responds to their child will impact on the child's attachment style. This attachment style is critical because it forms a template of how we build, the template of how we build future relationships with others in our lives, and also a template for how we feel about ourselves and other people. There is research evidence and supportive programs which help parents and practitioners understand this process. And in Bristol Early Years, we have adopted the 5 to Thrive approach. The 5 to 5 model identifies 5 key parental activities which actively help develop brains through mindful soothing and stimulation. Firstly, responding and assessing a need; cuddle, connecting and engaging; relax, self-regulating of stress; play, being playful; and talk, creating a narrative. You can find more out about the 5 to Thrive rollout across Bristol Early Years on the Early Years page of the Bristol City website, or you can signpost parents to children's centres and family support services. And finally, ACEs, or Adverse Childhood Experiences. These are highly stressful and potentially traumatic events or situations that occur during pregnancy, childhood, and/or adolescence, and can have an impact on physical and mental health throughout life. There is no definitive list of ACEs, and ongoing research continues to add to the understanding of ACEs and the risks associated with them. Examples of experiences that are deemed traumatic include physical, emotional neglect and abuse, mental health, substance misuse, DV, lack of stability in the home, poverty and homelessness. Evidence suggests the risk to health and well-being increases with the number of ACEs a person may experience. Having ACEs will impact on parenting approaches, understanding and capacity. However, having access to early support can mitigate the risks of negative impact in later life. As research is gathered and our understanding deepens, there is more information and support for people who identify as having ACEs. Bristol City Council aims to be a city where we can disrupt the intergenerational cycle by preventing ACEs in our young people and strengthening resilience in individuals, families and communities, leading to better life outcomes. Bristol City Council set out an ambition to work towards being a trauma-informed city in Bristol One City Plan. Parents and professionals can get more information about this on the Bristol City website.
So here are some useful links, as promised, to policies, websites and information we have mentioned today. That is literally the end of our webinar, but obviously if people have got questions, now is the time.